Yeah, thank you very much for having me. Good evening, everyone. My name's Aaron. I'm a glaucoma specialist in Auckland. I work at Auckland Eye. I also work at the public eye clinics in Green Lane, in Waitakere, and also at Manukau. And I want to talk to you guys about neuroprotection this evening. There's a lot of information out there about glaucoma and neuroprotection, and there's a lot of stuff coming out. And I just wanted to kind of give you my overview of what we have achieved and what's still to come. So yeah, I thought it'd be a good one to kind of, talk about a lot of the stuff that's coming out and kind of cover that. Just a little bit about me. I'm a Aucklander. I went to medical school in Otago and I've trained all over the country. After my general eye training, I've done subspecialty fellowships, two fellowships in glaucoma, one in cataract, and my last one was in Sydney Eye Hospital doing glaucoma. And these are my two kids, Dylan and Cara, who keep me really busy when I'm not at the hospital. So to start with, when we're talking about neuroprotection, I think we really need to understand what we're treating with glaucoma. And so with glaucoma, we know that the problem starts with these retinal ganglion cells, and we don't quite know how or why it happens, but we know that they're the cells that seem to get lost. So the retinal ganglion cells are here. So if this cross section is your retina, the photoreceptors are on the bottom layer and they send the signals up through a myriad of different cells. And the last ones are the ganglion cells, and they take the message out from the retina through the optic nerve to the brain. So they're a really important cell in the signaling pathway of your eye. Right now, the only way that we can treat glaucoma is by modifying a risk factor, which we know is intraocular pressure. We know that this pressure of your eyeball is really important for the health of these retinal ganglion cells. And so all of our current treatments that we have and that we know work aim to lower the intraocular pressure. And we know that that eye pressure is all to do with the fluid flow in the front of the eye. So this diagram here on the right is the anterior chamber which is filled with sort of watery aqueous humor. It gets made behind the iris and it flows through the pupil and through the drainage system here in the angle. So all of our treatments focus on that system and trying to change that to change the pressure in the eye. But what if there was a different way? And so that's what neuroprotection is about. Neuroprotection is a really broad term, but it basically refers to any type of treatment that we can do for glaucoma that's not related to lowering the pressure. And really, this is sometimes referred to as a holy grail, because if we can achieve this, it would really be applicable to almost anyone with glaucoma. And it'd be a completely different way of treating the disease than focusing on the pressure. At the moment, we're getting more and more evidence that this might be something that we can do, but on the flip side, there's nothing that we can say is clinically accepted. It's not something that there's no treatments that are accepted around the world as something that definitely is definitive and has a good effect and we should be doing for all of our patients. I do think, though, that as this is something that we're looking at more and more, it's likely to play a large role in how we manage glaucoma in the future. So it's something to be on the lookout for. So the fact that we haven't had a clinically accepted treatment doesn't mean that we haven't been trying. And there are a lot of different things that we've looked at in order to protect these retinal ganglion cells. These are just some of the ones that we've looked at, and I'm not going to talk about all of them tonight, but I'm just going to talk about a select few of the ones that are interesting at the moment. So the very first one is nicotinamide, and I think we've heard quite a lot about this recently. It's a form of vitamin B3, and the way I remember B3 is thinking about your eyes being free. Um, Vitamin B3 has different forms, so it's really important to know that the one that we're talking about in glaucoma is called nicotinamide, but it's also called niacinamide. This one is the one that has the most evidence and is currently available as a supplement for skin cancer prevention. There are other forms, but they're not ones that have been studied in terms of glaucoma, The original one is niacin, but that has lots of side effects, including skin flushing. And there is another form called nicotinamide riboside, which sounds similar, but is not the one that we've looked at. It's probably a little bit newer, but there's less evidence about its safety and its use in other conditions. So it's not something that we've looked at as yet. So why nicotinamide? Well, nicotinamide and all of those forms of vitamin B3 get converted into something called nicotine adenine dinucleotide when it's given to you. So this compound is really important for the mitochondria, and the mitochondria are like a part of your cell that is like the cell's battery. It's its energy source. And every cell has mitochondria, but the retinal ganglion cells need a lot of energy to take that signal from all the way from your eye all the way to the brain because it's a long pathway it has to go through. The retinal NAD levels seem to decline with age, and the thinking was that this leaves ganglion cells vulnerable to stress, and that stress might be in the form of the eye pressure. So in models of glaucoma in mice, they've shown that oral nicotinamide can protect the retinal ganglion cells from a pressure-related stress event. So this led to this study, which was published in 2020. This is a study they did in Australia, and they gave oral nicotinamide, vitamin D3, to patients with already diagnosed glaucoma. This was only in 57 patients, so that's not very many for a clinical trial. But I think the really clever thing they did is all of those 57 patients went through both the placebo, so no drug, and they also went through the course of the nicotinamide, and those were spaced out. So they had 12 weeks of each. The other really clever thing they did with this study is because glaucoma is such a slowly progressive condition, it's hard to often see an effect in the course of, say, 12 weeks. You might have to wait years to really see a true effect from something. So one way they used to sort of accelerate seeing those changes was to use a thing called an electroretinogram. So this is not something that we'd typically do for our glaucoma patients, but it uses electrodes that are placed around the eye, and then the patient is placed in a stimulus-free environment and given very specific stimuli to their eye, and then the electrodes measure the electrical outputs that come from around the eye. By doing that and looking at these electrical outputs, you can very specifically see the function of the different cells involved in that visual pathway, like the photoreceptors and the retinal ganglion cells. So what they did is they looked at nicotinamide for 3 months and then measured the retinal ganglion cell function with this electroretinogram, and they found a 15% increase in the function of these cells after the 3 months of nicotinamide compared to when they got the placebo. The increase was only 5%. So it was statistically significant, and it seemed to suggest that the retinal ganglion cells were responding to the treatment even after 3 months. They did also look at visual fields, so you'll be more familiar with visual fields. They're the way that we measure glaucoma progression, and they're looking at the peripheral vision that's lost. And this is a typical visual field that's slowly losing field going down the slide. When they looked at the visual fields of these patients given nicotinamide, the mean deviation, which is a number given to how much field damage is occurring in that visual field, it seemed that the patients after they had the nicotinamide were doing better in terms of those compared to when they had the placebo, but that difference wasn't actually statistically significant, unlike the electroretinogram. So it seemed to be a trend towards that being better than placebo, but it wasn't significant. So we couldn't say it wasn't due to random chance. And this is probably to be expected because, like I said, it was only a short period of time in which they measured between visual fields. You'll know yourself, having visual fields for glaucoma, often they're not done, for more than 6 months, 12 months, or even longer. So really to find a difference within 3 months is going to be pretty difficult. So all of this work done before 2020 has resulted in a bigger study. So they're doing a multi-center randomized controlled trial, which is due to complete in 2027. What they're doing this time is they're still giving the same nicotinamide, but they're looking at over a longer period. So this is 2 years, and they're taking the same measurements and visual fields as well as OCTs, which are another way that we monitor glaucoma, and the ERG that they used originally. So I think this is going to be really exciting when this comes out. This is going to show us really what is the long-term effect of this treatment, and is it something that is truly working? Because it's quite exciting what they found in 3 months. I think there are some limitations to be taken away from this, and the dose of the nicotinamide is pretty high that they're using. So this is Blackmore's Insular, which is the commercially available in your pharmacy version of nicotinamide. They actually use this exact product for the study, but the patients who are on the full treatment dose have to use 6 tablets a day. And that's not only just a lot of tablets to take in one day, but it's a lot of nicotinamide. With such a high dose of nicotinamide, there is a risk of drug-induced liver toxicity. And in the several trials that are going on, that 2 patients out of about 300 have actually had this drug-induced liver injury. So it is not without its side effects or adverse effects. And even though it's a vitamin that's available over the counter, it is something that can harm you if you have enough. The other issue may be cost. So a 60 tablet bottle of the Blackmore's Insular goes for around about 20 New Zealand dollars. So taking 6 tablets is going to, end up costing about $2 a day. We don't know how long you need to keep on taking this for. So, the thinking, if it is due to, your NAD levels going down with age, is that you may need to do this lifelong. So this can be quite a costly treatment for you long term. So that's enough about nicotinamide for now. I wanted to talk very briefly about another medication called memantine. Now, memantine, you may have heard of or not. This is more of a tale of caution. So this is a medication that is available for Alzheimer's disease. The idea was that it blocks this receptor, the NMDA receptor, which is present in our neurons and neuronal cells. And the idea being that if it blocks this receptor, sometimes those cells that are dying or sick might transmit a message to its neighbor saying that I'm sick, you should be sick too. And it stops this sort of cascade of these cells dying. It's shown in animal glaucoma models to protect the retinal ganglion cells. So it was very positive at the outset, and people were very excited about this about 10 years ago. Again, like I said, they had to go through the usual process where they get a lot of patients, they randomize them to having memantine or a placebo, and this cost millions of dollars. But after 5 years of looking at this really hard, they found no effect on glaucoma. And this was published in 2018. And essentially, memantine is not something that we recommend at all now. So there is no evidence for this. So there are times that these medications come along, we get really excited, and we find with time the effect isn't what we thought it would be. Another neuroprotection agent that's often talked about is ginkgo. So ginkgo has been around for a very long time, the extract from this plant, and it's often been suggested that it has a neuroprotective effect. It's also known to be an antioxidant, and it may also affect your vascular supply, so maybe helping the vascular supply in the optic nerve. It's something that I've heard about for a very long time, and all through my ophthalmology training. And I decided to have a better look at the evidence, and I found really that the evidence in ginkgo probably isn't that strong. It hasn't been looked at that in depth. What I was looking for was prospective evidence. So trials when they looked at patients from the outset and decided, okay, you're going to have ginkgo and you're going to have not the ginkgo, because that's the ultimate way. If you can randomize people to having the treatment or no treatment, that's how you're going to really find if the effect is true. And there's only really two trials that I could find looking at this. And both of these trials were relatively small, less than 30 patients each. And actually, the evidence between these two trials is conflicting. One of them shows that there's benefit in normal tension glaucoma, and one showed no real difference. So even within that, I think the evidence isn't that strong. There certainly are quite a few retrospective studies. So these are studies that where they've decided I want to look at ginkgo biloba, and I know I have a lot of patients who take it, and so I'll look backwards and see what, whether the people who had ginkgo biloba do better than the patients who didn't get it or got something else. And there are a few studies looking at this retrospectively with quite a few patients, but I have to say, looking at some of them, you sort of wonder what this selection process was for those getting ginkgo biloba or the other treatment. And those selection processes were not randomized, and they did acknowledge that these studies may have some effect of selection bias. And if they don't mention it at all why they selected one treatment over the other, you have to only assume that there be a degree of selection bias there. So it's hard to know if that is a true effect or not. The other thing with ginkgo is there are case reports of problems occurring to patients with the ginkgo. So they can develop blood problems after having this. And there's this possible interaction with an enzyme called cytochrome P450. This is something that we learn a lot about at medical school because it's a key enzyme in your liver that's involved in the breakdown of a lot of medications. And on the right is just an example of some of the medications that are broken down by this family of enzymes, and you'll see a lot of familiar names and potentially medications you may already be on. So there is a potential for the ginkgo biloba to change the way that that medication that you may already be on gets broken down and can change the effect of it. So there's something that has a potential for harm as well. Another exciting thing I wanted to talk about was a new implant that they're researching, the CNTF implant. So this has a neurotrophic factor called ciliary neurotrophic factor, or CNTF. This is something that occurs naturally in our bodies and our neural cells, and it's been shown in animals that it can protect retinal ganglion cells. So the team at Stanford have come up with this implant called the NT501. What they've done is they've modified RPE cells, which are retinal pigment epithelial cells. So these are cells that are derived from an eye, from your retina, and they've genetically modified them so that they produce a high level of this neurotrophic factor, CNTF. They've then put these cells in this little device that they've designed, and it has this semi-permeable membrane. This keeps the cells within the device, and it lets nutrients come into the device and lets the CNTF, the neurotrophic factor, come out of the device. So it sits there constantly putting out a lot of this neurotrophic factor. The device is implanted into the back of the eye, into the vitreous, and lets out this CNTF factor. And they've done a trial where they looked at 11 patients, and they followed these patients for 18 months. And they found that there were no major adverse effects of having this implant put into the eye. It's a relatively large operation to put something like this in your eye. But they showed less progression of glaucoma in the small amount of patients. And in fact, they showed a thickening, so a more of the retinal nerve fibers as measured by an OCT, which is really exciting, right? That's creating more nerve fibers potentially with this neurotrophic factor. So the next phase is underway, and they're putting this in more patients and longer term. So that's really exciting. One last area I wanted to talk about was gene therapy. I wanted to talk about this not necessarily because there's anything that I can see right now, but I think this is an area that's going to change in ophthalmology very, very soon. Gene therapy has already been approved for use in other eye conditions. So these are mainly in retinal conditions. Things like inherited retinal problems, which might occur in a child that they've inherited from their children, from their parents, and they've got a very specific mutation in their genetics. We now have gene therapies that might be able to fix those problems or replace whatever's missing from that retinal issue. And that's been approved already, and that's really exciting. So, people have started to look at this for glaucoma as well. There is nothing in humans as yet, but these are some of the examples of the things that were looked at in mice and cellular studies. And you can see in the top right here that the neuroprotection is something that they're really looking at, and things like neurotrophic factors such as CNTF and similar are being kind of researched. It was whether we can modify the cells in your eye to put out these factors in order to create more resilience, perhaps, with your optic nerve and protect these retinal ganglion cells. They're also looking at gene therapies that might target the front of the eye, and how I talked about earlier the intraocular pressure and the outflow system of the eye. If we can maybe get the cells in the front of the eye to produce something that will decrease the intraocular pressure, that could be another potentially new treatment for glaucoma. And really, I thought of these treatments, gene therapy still in my mind sounds like something that we're not going to be doing anytime soon. It sounds like something way in the future. But actually, at Auckland Eye, recently they've been recruiting for a research study looking at gene therapy, not in glaucoma, in macular degeneration. So that's really exciting. These sort of treatments are available for other eye conditions, even in New Zealand. And it sort of reminded me to point out that at Auckland Eye, the research team are doing a lot of research, including in glaucoma. So we're going to be recruiting soon for a study looking at glaucoma and cataract surgery. So these studies, obviously, if you're eligible, will pay for the treatment and the visits as by the study. So as a way to access treatment. If this is something that you might be interested in, feel free to look up the Auckland Eye website. You can use this QR code on the right, or you can just Google Auckland Eye Research. That'll take you straight to the page, or go to the Auckland Eye website and go into the Research tab. You can register your interest, and the research team can contact you if they think there's something that might be suitable for you coming up in the future. So here are some of my conclusions. I think, with neuroprotection, there is a lot of hope, and I'm hoping to give you hope without the hype necessarily. I have no vested interest in any of these, but, I think there are things changing, and, we have to look, though, at some of the times that we've had failures. Not all of these are going to work necessarily, and we have to be sure that they work because we don't want to cause people problems. That's the Hippocratic Oath. We can't first do no harm. We don't want to cause you problems before we promise something. So the research into neuroprotection, I think, will change our management of glaucoma. I'd say nicotinamide is promising, but right now I think it's safest to stick to a dose that's not as high as the trials. 500 milligrams once to twice a day is sort of what we do for skin cancer prevention. That is probably a safe dose, up to 3 times a day, really. I think higher than that, we are kind of getting close to the territory where we may be causing harm. And without really knowing the true effect of this long term, it's probably not worthwhile. And hopefully that'll change after the study results come out in a few years. Ginkgo, although there is some evidence, I think it's smaller evidence, and memantine really shouldn't be recommended. I think in the future we'll be looking at brand new treatments, things like maybe the CNTF implant and maybe even gene therapy. I think they hold a lot of promise for future glaucoma management. And so thank you very much. And that's all I had to talk about for neuroprotection, but I'd be very happy to answer any questions that you might have had.